All right, let's just start so we can get everyone out of here on time. My name is Shahriar Zehtabchi. I am a faculty from State University of New York Downstate Medical Center. I am also the editor-in-chief for the evidence-based medicine website, the NNT.com, which doesn't involve any financial compensation or any financial conflict of interest. Unfortunately, my co-presenter, Dr. Joe Habboushe, who is the co-founder and CEO of MD Calc, he couldn't make it today, so I will be doing the lecture. Even as doctors, we all need help to, sometimes we need help to understand the true benefits and harms from specific treatments or procedures. It's all about presentation. It's all about how the data is presented to us, right? So it could be like this or this. It's all about presentation. So in the next few minutes, I will very briefly, very quickly go through what we call measures of effect size, odds ratio, relative risk reduction, absolute risk reduction or absolute risk difference, and number needed to treat. This is not a statistics lecture. It will be very quick, very brief, and then we move on to the fun part, which will be going through some of the actual studies and systematic reviews to see how they present the data and what the real numbers are. So let's start with risk. Risk represents the likelihood of an event or an outcome in a specific population. Number of patients with an outcome divided by total N. So if you throw a dice, and I just recently learned that dice now can be used as singular and plural for dice. So if you throw a dice, the risk of having a 1 is 1 to 6 because you have total options 1, 2, 3, 4, 5, 6, and risk of having 1 is 1 option out of 6 options. So the risk of having 1 is 1 to 6 or 17%. Odds, however, is the number of event to number of non-events, number of patients with an outcome divided by number of patients without the outcome. So looking at the same dice example, you have 6 options. 1 option is 1, and 5 options are not 1. So the odds will be 1 divided by 5. Okay? So if you have 1 dice that has a risk of 1 to 5, risk of having a 1 to 5, and you throw another dice and you have another risk of 1 to 5. So the ratio of these risks, which what we call risk ratio or relative risk or hazard ratio, will be 1. Okay, so this is a very simplified version. The odds will be the same. You have the odds of 1 in 1 dice as 17% or 1 to 5. Odds of a 1 in the second group as 1 to 5, your ratio of 2 odds or your odds ratio will be 1. So let's say in this example we have, we can get the, let's say we have a hypothetical study. We have 100 patients in the exposed group, 100 patients in the control group. In the exposed group, 10 patients had the outcome. In the control group, 12 patients had the outcome. So if you want to calculate odds ratio, the odds will be events to non-events, or patients with the outcome divided by patients without the outcome. So in this case, the odds will be 10 out of 90, correct? So 10 out of 90, 11%, and in this group will be 12 divided by 88. You have 2 odds, you divide the odds in the exposed group divided by odds in the control group, and you have your odds ratio 0.79. For risk ratio, you have the number of events divided by total N in that group. So here, the risk will be 10%. Here, the risk will be 12%, and the risk ratio will be 10% divided by 12%, 0.83. As you can see, when the prevalence of the disease or prevalence of the outcome is small, odds ratios and relative risk are very close. As the prevalence of disease or prevalence of outcome increases, then they become different numbers. So what about relative risk reduction, absolute risk difference, and number needed to treat? Let's use the same example that we had a relative risk of 0.83. If you do 1 minus relative risk, you will have something that's called relative risk reduction. In this case, it will be 17%. With a number that represents the relative risk decrease in the exposed patient divided by non-exposed patient. And you can see, you will say, why did you do that, right? So relative risk is, by itself, is not very intuitive. So even when you hear a relative risk of 0.4, you have to think what it really mean, and then you do 1 minus relative risk. Why would you do that? We'll get to that part. If you want to present the risk reduction or risk increase, your best option is absolute risk difference, because it is very simple. It's an absolute number. If you have, in one group, you have the risk is 10%, in another group, the risk is 12%, your relative risk difference is 2%. So you can tell your patients that if you use this, if I give you this treatment, or if you do this procedure, your risk is going to go from 12% to 10%. You have 2% less chance of having the outcome. So absolute risk reduction, but I like to use absolute risk difference because the absolute risk might go up or go down. And a number needed to treat, thank you. So what about number needed to treat? When you have a treatment or a procedure, there are a number of patients who will benefit from the treatment. There are patients who will not benefit from treatment, and there will be patients who will be harmed by the treatment, right? Number needed to treat gives you exactly that information. It's calculated by dividing 1 to absolute risk difference, and in this case, number needed to treat of 50 means you have to treat 50 patients with this treatment for 1 to benefit from it. What about the other 49 patients? They're not going to benefit from it. And then for number needed to harm, when you have the absolute risk reduction, you do the same, 1 divided by the absolute risk difference for harm, and then you will say you need this number of patients to be treated with this treatment for 1 to be harmed, rash, diarrhea, death. So it's a very easy way to communicate with your patients, with your colleagues, and patients understand this. You can tell them that I need to treat this number of patients for 1 to benefit from the treatment. All right, let's do the fun part. This is a NINDS trial on TPA. I know TPA is very controversial. We are not talking about the methodology of the paper. We're just looking at how the numbers are presented. A few months ago, I had a patient who had a stroke. She came within 3 hours, and the neurologist wanted to give TPA. And I followed the neurology resident who went inside the room. He leaned on the door and very confidently told the patient, if I give you this medication, there is 30% chance that you will get better. When he came out, I approached him and I said, where did you get this 30%? And he said, it's in NINDS paper. You should look it up, which I did. So I gathered my crew and we pulled up the paper with residents, and the abstract says, by the way, before we do this, what percentage of physicians do you think only read the abstract? Yeah. So my non-scientific poll is probably 95%, if not more, right? People just look at the abstract. So this neurology resident most likely just looked at the abstract, and the abstract says, as compared with patients given placebo, patients treated with TPA were at least 30% more likely to have minimal or no disability at 3 months on the assessment scales. So you don't see any word relative or relative risk reduction here, right? You just see 30% more likely to have favorable outcome. This is the outcome table. And they use different scales. If you do use each of the scales will give you the same results. But just let's use Bartle index. And as you can see here, the number of patients, this still doesn't work. So we use Bartle index. And the rate or the risk of favorable outcome in the TPA group is 50 divided by 168, right? Because we are doing risk, not odds. So it's number of patients with that favorable outcome divided by total N. 30% will have favorable outcome in the TPA group, and 23% had favorable outcome in the control group. The absolute risk difference is 7%. So actually, if you give TPA to the patient, there is 7% chance that they will have, 7% more patients will have favorable outcome, right? And your NNT is 14, 1 divided by absolute risk difference. So you need to give TPA to 14 patients under 3 hours for 1 to benefit from TPA. So where did the 30% come from? If you calculate relative risk is the risk of event or outcome in the exposed group divided by control group. So 30% divided by 23%, you'll get a relative risk of 1.3. And if you do 1 minus that, you'll get 30%. So this 30% is actually relative risk reduction. It's not absolute risk, and that's where it comes from. Do you get it why they use relative risk reduction instead of absolute risk reduction? Let's do another example. Oh, by the way, if you want to do odds, it will be number of patients with the favorable outcome divided by patients without favorable outcome, right? Remember? So it will be 0.42 divided by 0.3, and your odds ratio will be 1.4, which is very similar to your relative risk because the prevalence is not very high. So this is my all-time favorite paper because this is sponsored by some pharmaceutical company that makes Tamiflu. So they looked at databases of insurance companies. They found the children who were tested positive for flu, and they looked at how many of those patients got pneumonia in 2 groups of patients who got Tamiflu or those who didn't get Tamiflu. So the outcome is pneumonia caused by influenza in patients on Tamiflu and those without Tamiflu. And the way they defined positive cases is pneumonia in the index visit or in the subsequent visit. So imagine if a kid had influenza today, went home, 2 years later, the kid had pneumonia. They call this a pneumonia caused by influenza, right? So it's very fishy, but we are not talking about the methodology and how they define their outcome. We are just looking at how they reported their outcomes, correct? So the outcome here is whether you should, the question is whether you should give Tamiflu to children to prevent pneumonia. And the abstract says, right at the bottom, overall children who received Tamiflu for the treatment, I can't pronounce this, overall children who received Tamiflu for the treatment of physician-diagnosed influenza were 51.7% less likely to be clinically diagnosed with pneumonia at a subsequent medical encounter. This is amazing, right? What treatment do you have that reduces the risk by 52%? If you are a pediatrician or a family physician and you see this in an abstract, you're going to pick up your pen and going to start writing Tamiflu for every kid who has influenza. This is an amazing number. Agreed? Let's look at the numbers. So this is their outcome table. They looked at pneumonia and also hospitalization. So the risk of pneumonia in the study group in kids who got Tamiflu was 0.65%. In control group, it was 279 divided by this number because we are looking at risk again. Number of patients with the outcome divided by total N was 1.4%. So absolute risk difference was 0.75%. So if you are you're in this game to make billions of dollars, you're not going to send your drug reps to the physician's offices and say, if you have a child with influenza and you give them Tamiflu, you're going to reduce the risk of pneumonia by 0.75%, right? What would you do? You and then NNT of 133. So you have to treat 133 patients for one, to avoid or prevent one pneumonia. So what would you do? You calculate the relative risk, which is 0.65% divided by 1.4%, and you get a relative risk of 0.6, and relative risk reduction will be 54%. You put this in your abstract, and you accidentally drop the word relative, and you're golden, right? But even without calculating the numbers, you can look at this. The risk of pneumonia in the study group and in the control group, this is not a thing. Pneumonia after influenza, it's really not a thing. The numbers are so low, it just doesn't exist. But they still went on to really, really make billions of dollars on Tamiflu because of a paper like this, just by manipulating the numbers. For hospitalization, the risk in the study group is 0.11%, 0.14%, and absolute risk reduction is 0.03% with an NNT of more than 3,000. So you need to treat more than 3,000 children with influenza with Tamiflu to prevent one hospitalization. But relative risk is 0.79 and relative risk reduction is 21%. So the 21% is what's going to make it to the paper, not that 0.03%. But you can look at the paper and really easily extract these numbers, do a quick math, and you have your answer. You don't need to believe what they will tell you. So this is not, unfortunately, it's not always the pharmaceutical company that do this. Some of the most reputable organizations like Cochrane sometimes do this as well, and it could be confusing to people. This is a Cochrane review on probiotics for prevention of Clostridium difficile associated diarrhea in adults and children. So if you're putting someone on antibiotics, whether giving probiotic concomitantly will reduce the risk of C. diff diarrhea. This is a really valid research question, and when you read the abstract, it says the data suggests that probiotics reduce the risk of CDAD by 60%. This is amazing, right? You should be giving this to every patient who you prescribe antibiotic to. 60% is a very good number. However, when you do the numbers, the risk of CDAD in probiotic group is only 1.5%. The risk of CDAD in control group is only 4%. So the absolute risk difference, 2.5%, right? And that will give you a number needed to treat of 40. This is still not bad, right? 1 out of 40 you can prevent a C. diff diarrhea. That's not bad, but it's definitely not 60%. Your relative risk will be 1.5 divided by 4, and it gives you 0.4, and relative risk reduction is 60%. That's where they got, that's what the 60% comes from. What is really irritating is when they report the benefit with relative risk reduction, but when it comes to harm, they give you the raw numbers, right? They give you risk of CDAD in probiotic group is, this one. The incidence of reported adverse events, they give you 14.3% and 17% with an absolute risk reduction, absolute risk increase of about 3%. So they don't do relative risk reduction because that number would be 17% and they would be exaggerating the harm. They only give you the raw numbers here. I'm pretty sure all of you have a family member or someone that you know who had an abnormal EKG or an abnormal stress test, was seen by a cardiologist, and ended up on the cath lab for PCI and got stent, right? this is the most cited meta-analysis on this topic, and it looks at patients who have obstructive coronary artery disease, but they're asymptomatic. They are not having ischemia at the time. And this meta-analysis showed that the stenting of patients with a stable obstructive coronary artery disease does not reduce mortality, does not reduce non-fatal MI, and does not reduce anginal symptoms. The reason why I put this here is because I want to show you that when your odds ratio of 95% confidence interval for odds ratio crosses 1, that means that the true number could be 1. And when the true ratio is 1, that means the risk in two groups could be the same, which is absolute difference of 0. So your number needed to treat will be 1 divided by 0, infinity, or you have to treat infinite number of patients for 1 to benefit. So that's why when first of all odds ratios and all relative risks have to be presented with 95% confidence interval. And if you see that 95% confidence interval crosses 1, that's not statistically significant, and you don't calculate number needed to harm or number needed to treat. There's no benefit. There's no point in doing anything further. So my father is in his late 70s, and he's very active. He can walk miles at a time without breaking a sweat. Never had chest pain in his life. Never had shortness of breath in his life. But for the past 30 years, every time he goes for a checkup, his EKG is abnormal, and they sent him for a stress test. His stress test is usually non-conclusive, so they tell him that he needs to get a cath. And a few months ago, he went to his cardiologist, and the cardiologist just outright told him that if you don't have angiography and possibly angioplasty, you are going to have a heart attack and you're going to die. So he called me in panic and said, what do you think? And I said, well, ask your questions and we'll talk about it. So his first question was, if I don't do this test, am I going to have a heart attack? And my answer was, well, you might have a heart attack, but whether you do this test or not is not going to change the risk, right? That's what the odds ratio says. Those, okay, am I going to die? And my answer was, well, you might die, but whether you do the test or not is not going to change the risk. Okay, could this test be harmful? So the number needed to harm for angiography is the absolute risk difference is 2%, so number needed to harm is 50. So 1 out of every 50 patients who get cath, they will experience major bleeding, MI, or stroke because of the procedure. So I told him, yes, every 50 patients who gets on the cath table, one of them will have these side effects for absolutely no benefit, right? So there was a long pause on the other side of the phone, and at the end he said, seems like my cardiologist benefits from this test more than I do, which is true. Somebody has to pay for the Mercedes, right? So this was how he acted in his cardiology office. All right, let's close with aspirin. This is a very recent systematic review for aspirin use for primary prevention of cardiovascular disease. This is the key point is primary. So this is giving aspirin to people who have never had a heart attack or TIA or a stroke to prevent those things. And we've been giving this to people for decades to prevent cardiovascular disease without really any solid evidence. And luckily in 2018, several large RCTs were published, and this systematic review came out that included all those RCTs, and here is the table. I love this systematic review because it gives you all the outcomes separately. It reports the composite outcome, which was reported by some of those RCTs, but it also gives you the breakdown of each outcome. When you see composite outcome, ignore it because it only composite outcomes are designed to find statistical significance. You want to look at individual outcomes, right? And again, they even give you the absolute risk reductions or absolute risk differences with 95% confidence interval and relative risks. So this is great. This is a great table. So aspirin, all-cause mortality, no benefit. Why? The relative risk crosses 1, not statistically significant. For cardiovascular mortality, no benefit. Relative risk crosses 1, right? So you don't calculate NNT. The NNT for preventing one myocardial infarction is 357. So 357 patients need to take aspirin daily for one of them to avoid a heart attack. And for stroke is 625. Again, 625 patients need to take aspirin daily for one stroke to be prevented. And below you can see the number needed to harm for major bleeding, intracranial bleeding, and major GI bleeding. So this doesn't look good for aspirin, but does it mean you're not going to offer aspirin to your patients? What would you do with these numbers? The take-home point for NNT and NNH is that these are numbers that are easily understandable. You can communicate them with the patient, but they don't tell you whether you should use a treatment or not to use it. It's a piece of information that you will use in your decision making and hopefully shared decision making. You bring up these numbers to the patient and you decide what is good for the patient. Remember, evidence-based medicine has 3 components, right? Clinical judgment, research, and what is the third one? Patient preferences and circumstances, right? So one patient might tell you that, we have a lot of heart attack in my family. My father died from heart attack. My grandmother died from heart attack. I do not want to have a heart attack, and I am willing to take the risk of bleeding just to prevent heart attack. That's the right decision. That patient is okay to take aspirin. Someone might say, I am terrified of bleeding. I do not want to have any bleeding, and I am willing to take the risk of heart attack and stroke. He doesn't want to take the aspirin. That is still the right decision. So you see that NNT gives you the ammunition to talk to the patient and make decisions with the patient instead of telling you what is good or what is the right decision, what is not the right decision. The right decision could be either option. Just 2 more points. When you look at an RCT, you can look at the raw number and do what we did. You can just get the raw numbers and calculate the risk and relative risk from the raw numbers. But when you have a meta-analysis, you have the meta-analysis has to give you the absolute risk difference or NNT, because in the process of meta-analysis, they take into account several factors, including the size of the sample size and other factors. So the numbers that they get in the meta-analysis is not always the number that you get from calculating the raw numbers. So if most Cochrane reviews, they give you the absolute risk differences or the NNT, and those are the ones that you should use to get your NNTs. And again, if the number needed to treat, you don't have to calculate the number needed to treat if the relative risk, the 95% confidence interval for the relative risk or odds ratio crosses 1, because that means there's no significant, and your NNT will be infinite or infinity. All right, thank you very much. If there's any question, I'm happy to answer. Yes.
Can you explain in general what someone would use risk versus odds ratio? In general, trying to...
Yes, of course. Thank you. So relative risk is something that is more intuitive, and this is what is preferable to odds ratio, and it is calculated in prospective studies. For mathematicians and statisticians, they love odds ratio because it's mathematically stable, and the formulas incorporated in logistic regression and multivariate analysis, they produce odds ratios. So we used odds ratio from in the retrospective studies or logistic regressions, and we use them as an estimate of relative risk. So what we really want is relative risk, but sometimes you have to deal with odds ratio and use them as an estimate for relative risk. Any other question? All right, thank you everyone. Have a safe trip.